I'm extremely happy to introduce the second Zoom session of Thinking Science, Thinking Faith. Again, Adrian and I have been hoping for such sessions way before COVID-19. And Ian was one of the people we were going to discuss. He was going to present in York. And here he is, Professor Ian Cooke, from Sheffield University, Emeritus Professor. He's going to talk about medical ethics.
I'm delighted to have your invitation, and I hope that my presentation will provide some food for thought. My background is that I'm a gynecologist, and some aspects of gynecology I concentrated on for a number of years, and it was divided into a number of areas, and in particular the one that I was interested in was reproductive medicine, and that's the one I've concentrated on. So I was an academic, and after I retired, I was involved internationally in low resource economies, often speaking about ethics and clinical matters, and I still contribute to some master's programs. So although I'm not an ethicist, I have been involved in some ethical discussions over the years. And so I wanted just to touch on the background, which I won't dwell on because I think you're probably more expert at that than I. But there is a long history, and medical ethics really was emphasized by the Hippocratic Oath, various versions of which have come through to the present day. Indeed, our own medical school in Sheffield provides a variation of that for students on graduation, so it is still relevant, although somewhat modified. And then with various religious backgrounds, it's come through to a Manchester physician, Thomas Percival, who was said to have coined the phrase medical ethics. And then through the varying religious versions, it's come through liberal theory and particularly legal aspects, procedural justice, until what is now called ethics. Now I don't seem to be able to, good. So the two principal moral theories are utilitarianism and deontology, rights and duties, but there are three other areas that perhaps you're not so familiar with, and that is the Aristotelian virtue ethics, what might be presented by a patrician in Athens and his behavior, the ethics relation to sharing in a community, and then the rather legalistic one of contractarianism, which relates to the obligations between two individuals who develop a contract. So it's really only from there that I wish to start. And I was interested in this American analysis of the various ethical backgrounds, and I rather like the notions that of impartiality, rationality, consistency, and I'm not sure I like the term reversibility, the standards that apply no matter who makes the rules, but there's an element of consistency in that, and standardization is important. So that really brings us through to what we have taught the medical students for many years, this list that was produced by Beecham and Childress in a number of years ago, and the book has come through various editions. But beneficence, doing good; non-maleficence, not doing harm; autonomy, the patient basically makes the decision. That's particularly important in view of the history of paternalism that has been around medicine. And then justice has taken a much more central role in recent years with the distribution of resources and who actually gets treated. And there's a question of equity in there, and not so much equality, but equity, the person who has their needs fulfilled rather than everyone being treated equally. Then dignities become more and more important, and integrity with informed consent and confidentiality. So these are the basics that we mean when we refer to medical ethics. And it's not that different to what has been put forward over the years. And this is the American Medical Association, been updated many times since 1957, but the principles are there. And it's amazing that it reflects very much what Thomas Percival enunciated in a number of publications way back in 1803. So in the UK, there is a professional body called the General Medical Council, and we have to belong, and they register any medical practitioner which allows him to, or her to practice. So they are responsible for the standards that all doctors aspire to. And it's they put out a number of publications, and this list, I think, highlights the detail: knowledge, skills and performance, safety and quality, communication, partnership and teamwork, and maintaining trust. And if one breaches these reference lists, then one is likely to find oneself up before a disciplinary committee and at risk of losing one's registration and being unable to practice. So it's quite a powerful body. And there was a recent comment by the chair of their Good Practice Medical Review Advisory Forum: good medical practice is the bedrock that helps guide ethical decision-making. So what I wanted to do was to review some aspects, and then I will conclude with an emphasis on reproduction, but I want to talk a little bit about genetics and some of the current unresolved ethical issues that I think are going to occupy us for the next decade or so. So everything depends in medicine on evidence. And what do we mean by evidence? When I was a medical student, a senior consultant expressed an opinion, and that held all and that held sway. That's moved on a great deal, because now it's not so much opinion as what does the data say. And for any drug, and that's where it started, to be able to register a drug, there are animal studies and a limited number of human studies for registration. And later, once the drug has been used, the pharmaceutical industry and also any doctors finding complications notify the central body so that one can keep track. But the way that one tests whether a drug or treatment is effective is to document what happens, and not just listing the patients, but there are a number of variations on this theme of trial. And the most sophisticated, the highest grade, grade 1, is called the randomized controlled trial. And that means that you need a random system of allocation between someone who gets the treatment and someone who does not get the treatment. It's not up to you as the person conducting the treatment. And there also needs to be a comparative group of individuals who are otherwise almost the same or optimally identical, so that the two groups can be compared to look for effects. And this has become more sophisticated over the last 40 years, where you can now pick up the telephone and say, I'd like to admit my patient to a randomized controlled study. And you will have seen reference to this in the recent COVID pandemic, when individuals were recruited from an Oxford centre into such trials, which led to very effective and very early data development. There are principles in doing these, and I just spent a little time on it. And the acronym of PICOS, P-I-C-O-S, stands for: you have to identify the patient, the treatment you're going to give, the controls need to be as similar as possible, what you're actually going to measure, and then what's become important over the last few years is the sociological data about the individuals, their age, sex, ethnicity. And this is particularly important because if one's going to treat adults, then the data don't actually refer to children. If you're going to treat pregnant women, the data don't actually refer to pregnant women. So you have to recruit children to be able to treat children using the information that's been accumulated, and similarly for pregnant women. And I'll have something to say about the latter later. And also you need to say something about the environment, because rural individuals may not be the same as urban individuals working in an urban environment or in a factory, whatever. And then finally, you need to work out how many patients you need to be able to show differences between the two. For example, if you think that one agent has a 40% success rate and you want to show a better treatment that has a 60% success rate, then you will have to have enough patients to be able to show a 20% difference, and that might represent 500 or 600 patients. So the smaller the difference between the two groups, the larger the number of individuals. So if one is conducting studies, almost always nowadays, there will be an institutional ethics committee which will review your study before you're allowed to do it. And so in the box on the right, we've got a restatement of the values, the ethical principles that we follow. What's the benefit or potential benefit of the treatment? What is the harm that could be inflicted, the side effects? It has to be clear that the patient makes the decision. And very often, it's important to insist on equity. If there's no good evidence that a particular agent is more effective, then the only option one has really is to do a randomized controlled trial. And you could say that the treated person may get the benefit, but may not avoid the side effects. But those that do not get the treatment won't have any side effects, of course, but at the same time won't get any benefit. So until you know what the benefit might be, then it's important to submit an individual to such a study. The World Medical Association in 1964 developed the concept of the Hippocratic Oath into a huge document that is called the Helsinki Declaration. It's been amended many times since then, but one has to sign a document saying that one observes the statements and principles of the Helsinki Declaration to try and keep one in a high ethical standard. And then, of course, informed consent and confidentiality are important. So then one can start the study. The problem is that you may have a number of studies successively that show different results. So how do you know which is correct? And that's where mathematical analysis of so-called meta-analysis of the trials comes together. I'm sorry for spending so much time on this, but I think it's really quite important because it's this evidence that I use. Now, this is an incredibly busy slide, and I'll show it 3 or 4 times with different highlights. You'll see the list of numbers on the left. That's simply to show that this is a study, a meta-analysis of 6 papers that were published over a period of about 5 or 6 years. And it's very difficult to know because they have different answers. If I can move to the same one, you'll see that I've got 2 red boxes on the left and the right. So on the right-hand one, treatment A, treatment B. And this forest plot is a graphical means of showing at a glance whether or not a paper is of any value. So, and treatment A is the conventional treatment and treatment B is the new treatment. And you'll see a number of squares with the confidence limits. That's their whiskers. You can see them on either side. And the important thing is that on the left-hand side, there are fractions, and on the right side, full digits, full numbers. So if the results favor the conventional treatment, those dots would be on the right-hand side. And if it favors the new treatment, it would be on the left-hand side. The problem is those whiskers, which the confidence limits, in other words, if you repeated that study 100 times, 5% only would show a different result. And if we look at the left-hand box, you'll see the numbers. They're not important at the moment, but this highlights the numbers. And so you'll see on the left-hand side of the green circles, we have the complications called events, And then the next number, the total, is the total number of patients. So see, these are huge studies. And on the right-hand side, conventional IVF with a similar pattern. And the sum total is over 2,000. So this is a vast data collection. If we look at the graph on the right-hand side, the whisker plots, you'll see that I have 4 red arrows. And those are there because the whiskers come up to and beyond the figure 1, which means that it's possible that there's no difference at all in the 2 treatments in those studies. If you look at the 2 top green arrows, you'll see that those whiskers on the right-hand side do not reach 1. So they are significant statistically, and that favors the new treatment. And so the number of complications, the events, give a weighting, and so that's a mathematical manipulation. And so you have a large circle, a large diamond at the bottom of the graph, which gives you the net result. And that shows that in spite of the disagreement of all these papers, we now have a conclusion that shows that the new treatment is significantly better. At the same time, you'll see the bottom left and the top right, I've got some areas circled. And this is, I won't go into the details, but what's terribly important is to find bias in the way the study's done. And you'll see on the graph on the right, I've got a whole series of green pluses, which show that there is no bias in that particular one. And there's only one of those studies that actually shows no bias. And that's, it's interesting that that's the one, the third one down. The whisker plots come in because of the very large numbers. So when I talk about evidence, almost all studies or treatments nowadays have been subject to this vigorous mathematical analysis. So one can no longer does one have an opinion about whether this management is okay. We have good evidence that it is so. So let me move on. One of the striking things in medicine in the last few years has been a consciousness that social conditions actually influence health. And Sir Michael Marmot, who was the Professor of Epidemiology at University College London, wrote a groundbreaking document in which he referred to the social determinants of health. And this becomes important when equity is so central to an ethical appraisal, because the list of contributory causes to from poverty, which I've listed there, have a profound effect on an individual's health. So there becomes really, and this is political in a way, it becomes so important to take into account the social conditions of an individual in deciding how to treat them. They should get more resources, and that, of course, is a political decision. But this is a restatement in this slide of exactly what I had in the last one, but this relates to ethnic groups. And it's very clear that in my field of reproduction, someone treated with a test for a test tube baby, for example, if you're Black, you have double the prospect of a miscarriage than if you're white. We don't know why, but that has to be taken into account in the management. And that's true for so many other areas, because they smoke too much, they're in general more obese, and there's a much higher frequency of mental illness, to name a few. But you can see the list there that's really quite striking. Let me show you this particular graph. It looks busy, just stick to the right-hand side for the moment. What I'm really trying to point out in this social determinants of health, if you look at the red, this is a national study over 2 years of all babies born, single babies born in the UK. And there is a rate for being born early, preterm birth, a rate for being small, and a rate for losing a baby at birth, stillbirth. And what's very disturbing is that stillbirth is higher in Blacks and South Asians. Preterm birth is highest in the most deprived, and small for dates babies are highest in South Asians. And you can see this graphically in the left-hand panels. And so the blue, the quintiles, that's 20% starting on the left from the least deprived to the right, the most deprived at 20% intervals. And you'll see the blue is the overall average, and the pink blocks are the excessive demand, excessive losses in those particular categories. The top one's the loss of extra stillbirths. The middle one is excess preterm births, and the bottom one is too many very small babies. And you'll see on the left-hand three, that is socioeconomic deprivation, and you can see how it increases the more deprived you are. And if you look at the right-hand panel, the four racial groups, white, South Asian, Black, have different degrees of problems, and you can see the different heights of the pink. So there's very good evidence now nationally in the UK that your race and your social status have a profound effect on your health. And this is an example from reproduction. Let's move on. In America, there's a big organization for reproductive medicine, and they have a very active ethics committee, and they put out regular statements. And one of the ones I have shown here, and it's access to the various forms of assisted reproduction, particularly. I'm talking about test tube babies and other related questions. And so there's often bias against individuals. And what they're saying is that there's really no evidence, no ethical reason why single, unmarried persons or diverse sexuality should be any different, treated any differently to conventional individuals. And they should be treated free of discrimination, have to look after the children. And one of the problems is that if you have very strong religious views, particularly in the area of reproduction, you have no business inflicting that on your patient. And if it conflicts with what they want to do, you should really refer them on to somewhere else. And then the second one, which actually came a little earlier, was everyone worries about children being brought up by non-conventional parents, the transgender parents. There is no evidence that they suffer any harm from this, and considerable evidence that they do just as well as from conventional families. So we need to educate the staff so that you can provide relevant information and care for them. A problem that confronted us over the last 2 or 3 decades was what to do with human immunodeficiency virus, HIV. It's a retrovirus, which means that instead of DNA, it's got RNA that gets into the cells, and you can't cure anybody because it's in the cells. You can just stop the virus, which hijacks the cell mechanisms to create more virus. You can stop that virus circulating. And so that's antiretroviral treatment, ART. And if you take the treatment and you don't breastfeed the baby to pass it on in the milk, then it's quite likely that you can have a baby without being affected by HIV. And if you can go further and you can wash sperm and actually remove virus, because virus is not in the sperm, but in the fluid. And there's been a very interesting development in the last few years. What do you do if you have an HIV positive man and an HIV negative woman? Because by having regular intercourse, he may infect her. But if you take the ART before they're exposed to pregnancy, then it's likely you will stop the transmission of the HIV. So with that development of treatment, there's no reason to stop treating individuals if they want to have a baby. And there's been a lot of argument about this in the last few years, and you'll see that's a 2021 decision as the data and science have moved on. One of the interesting problems in recent years is the use of surrogacy. So if a woman can't have a baby, or maybe she had cancer and lost her womb or ovaries, then she would need to have someone else carry the baby. They may use her own eggs, or it's technically possible to do that now, or traditionally they use the surrogate's eggs. And that's been called procreative tourism because there's a 5-year waiting list for this in the UK, and or could be, but you can have surrogates much more readily abroad, and that's the tourism bit. There was an early case in the UK where baby Cotton, you may remember, where a woman offered to have a baby, have a pregnancy for her friend, altruistic surrogacy, but most of the surrogacy, particularly abroad, is paid for, so-called commercial surrogacy, and in the UK that's not legal. It's interesting though, if it should not be allowed, what if the surrogate actually wants to offer? And I was rather taken by a sociological study in India where a woman who had a moderate family offered to be a surrogate or some money, but the reason for her wanting to do it was so that she could make money to educate her own daughters. It's very difficult to disagree with that. And she was well looked after, and so one would be obliged to approve such a process. But it's been said that this is a bit Wild West out there, and if you go to places like Ukraine before the war, or Cyprus, then there aren't many there's no legal framework, and it really needs to be much better regulated. And so there are ethical issues in there. Should one allow this if it's primarily a commercial exercise and is badly regulated? Let me take one other point, and that is doing good, beneficence. It's as women get beyond the age of 40, their eggs are not very good quality, and they may need, if they're going to have a baby, to have egg donation. And with the technical aspects of in vitro fertilization, IVF, test tube baby, nowadays it's possible to stimulate the ovaries to produce multiple eggs, recover them with a needle, and fertilize them in a dish in vitro and transfer them to another person, either the person that owns the egg or, in this case, a donation. And one would want to screen the individual so that there was no problem, and you need to look after the individual that's donating the eggs. But it should be possible to do this. So this would be seen as a good process. One of the problems more recently has been the emphasis on dignity. And this is a study that took place in one of the poorer provinces in Pakistan a few years ago, and where the women having babies were treated appallingly. And there were a number of factors. And the third point, they were having their first babies. They were not so well off. They really didn't understand what was going on, and because of poor education and the lack of education within the health services, and they were often subject to abuse by the family, and simply because they didn't have a job and earning capacity, they were looked down upon for being housewives. And so there was a great deal of fuss about this, and I think this is not unknown in the UK, and you will have read reports of disrespectful care in public health facilities. So this is a loss of dignity and would conflict with one of our ethical principles. Let me move on. Most people have recessive genes, and I'll say a little bit more about this later. But it's possible to not to have a particular disease, but to be a carrier, so that if you happen to have a baby with another person who is a carrier, even though they may not know, then the 1 in 4 chance of the offspring having this particular disease. And whether one allows that, whether one looks prospectively for genetic screening, would be called clinical ethics. But with the COVID pandemic more recently, there's been a lot of emphasis on public health ethics. In other words, how should one deal with the population at large, not just the individual? If waves of infection are going to hit a population, then prevention is terribly important, and that requires a different mindset. And so, and I'll show something about that toward the end. And a question also I'll come back to is, with the technology developing, it's possible to check more and more individuals either before birth, before an embryo is put back into a womb, or at delivery. And one of the important questions, I think on my last slide, will be, should we test everybody about in future for this? So I'll come back to that. It's a fact that a tiny proportion of all babies in a neonatal intensive care unit have a genetic disease, and it's usually not recognized because the parents don't have it, or the prospect's not recognized. And so if we were to screen every baby that came into a neonatal intensive care unit, either because it was very small or because it was sick, that would be very reassuring. If we were to do that, then there are some diseases that are not recognized in a normal baby, but we know that the baby would develop illness later in life. So if you knew early, you could actually prevent that. Phenylketonuria is an example. In other words, what diet that child takes will determine whether it is able to function mentally properly in the future. That's a big question. And what if we don't do this and we don't look at it? Are we happy to accept future generations of abnormal babies or development, or children who are going to develop particular conditions in later life? And these are existing questions that haven't been adequately answered. But the question is, if you need consent, how do you get consent from a newborn baby? If you obtain such information early on, at what point do you ask the child whether it's too late, you've made a decision? What information do you pass on to that child? What if you have found that that child, for example, is likely to develop a breast cancer before the age of 40? When should they be given that information? And so there have been suggestions that there should be a young person's advisory group to put forward views about how to do this. Of course, you need all this information with the names taken out, anonymized data, because that helps you to work out frequencies, prevalence, and how one should react in many of these situations. The Dutch have done a recent study. It's possible, if one is having in vitro fertilization, to check an embryo before it is returned to the mother. And you can do some genetic testings. If you know that there is a disease in the family, you can actually stop the replacement of an embryo with that particular gene, for example, Huntington's chorea. And you would want to do that because it's a devastating disease. But one of the questions that's arisen in the last 3 or 4 years has been, with the development of a technique and being able to take out a defective gene anywhere in the whole collection of genes, from a normal cell or from an ovary, an egg cell, and this is called germline genome editing. In other words, you edit the chromosomal constitution of an individual, or some of the genes on the chromosome, and eliminate that particular gene so that the future recipient of the embryo will not give rise to a birth with a baby with that condition. And so the question asked of the Dutch people was, should we allow this? Look at the statement on the bottom. The technology is there now, but it's not very reliable and you can cause more problems. So it's not perfect, but the Dutch said, well, if there wasn't any other treatment, then yes, we should do that. But you can't help the humans to get better. You can't make them more intelligent, or you can't make them more beautiful. They're not realistic anyway at the moment, because these are only really available for what are called monogenic diseases, where a disease is caused by an abnormality in a single gene, whereas intelligence and beauty have many, many genes contributing, and you would not be able to manipulate all of them. That's why the so-called designer baby is really a fiction. But what was interesting, there's a bit of NIMBYism in there. The participants were strikingly averse for personal use. They didn't want it for themselves, but they weren't too unhappy about allowing it for other people. So one of the interesting things when the early days of IVF in the UK was that you had to take society with you. And so you had to discuss these possible new treatments and whether the society as a whole would be prepared to accept them. And one of the striking features in the IVF world was that there was extensive discussion and counseling about this, so society was much more willing and able to undertake this. Let me come back to pregnant women and COVID vaccination. One of the, it became apparent during the COVID pandemic that if you were pregnant, you had a 5 times greater chance of dying than if you were not pregnant. But pregnant women were discouraged from being vaccinated. Why? Because there was no evidence that the vaccines were useful, because nobody had vaccinated pregnant women in the past. So because there was no information, they were not vaccinated, and so they were exposed to much, much greater risk. In fact, of the 912 studies reported in the Lancet late last year, 80% of them had no pregnant women at all, so there was no evidence to support them. So that's one of the things that we have an obligation to do, to look at different groups such as pregnant women, such as children, that are likely to be subject to various diseases, and make sure that the treatments can be tested in them. So you can't say it's only a child, we can't subject a child to such a risk, but we have a randomized controlled trial, and I've talked about the balance of risk. So, and then this is an editorial in the New England Journal, which is the principal general medical journal in the US, but it reflects discussions in the UK. You know that that we recently had an investigation, an inquiry opening into the conduct of the pandemic at various levels. There seems to be a lot of emphasis on the patient's experience. But this paper makes some interesting points that there really should be ethicists included in the discussion, because we all heard endlessly on the television, we're following the science. But in fact, how do you balance the health impact, the economic impact, what happens in education and in society in general? And these are important elements as well. So it's not just medical. This has to be a much broader perspective. And there needs to be transparency about these discussions. Communitarian ethics and social justice become very important in these. It's not just a medical issue. And so there needs to be involvement democratically along with the technocrats, and so that everybody knows what's being discussed, how the decisions are being made, and there needs to be trust in this process. So the preparedness and the pandemic response, which will be looked at in the UK, we're told, needs to include ethicists because these are important issues. I came across this recently. This is an article written by a South African lawyer. And coming back to this germline editing, should you be able to take a gene that's considered to be abnormal out for the benefit of that individual and successive generations? And the African perspective was really very interesting. They say, your view is very Eurocentric and it probably developed way back. And it, in general, has led to a banning of the genome germline editing. But the Africans have got a different concept, and in terms of looking at how human an individual is. And one progresses along a journey of self-realization, which can only occur in a community, so that actually your individual genome doesn't matter very much. It's changing it as doesn't matter very much either, unless it interferes with your becoming a full member of the community. This is a very different perspective to a Eurocentric view. And I think it emphasizes that you need different ethnic groups, different philosophical perspectives in the discussion of these ethical issues. Okay, this is the last slide. Each human has about 20,000 genes, and each gene has two components. I'm just reading this through slowly. Usually one is more effective, and that's called a dominant. And there's the other one of the two is less effective and is usually recessive. But it's possible for there to be spontaneous mutations. So one of these becomes abnormal. And if you have an abnormal recessive, which doesn't cause a disease, that's a recessive. And if you have two normal parents, but each happen to have the same abnormal recessive gene, then that child has a 1 in 4 chance of having the two recessives, and that's a disease. So the commercial company recently, BioArray, has advertised a genetic test for recessive diseases, and they claim to be able to analyze, what's that, about 1/6 or 1/7 of the entire human genome. And they're pushing it to doctors in fertility clinics and say, you can screen your patients so that they don't have recessive disease risk. And they can screen the patients, they can screen donors who provide eggs or sperm, and we can work out whether you're at risk of having an affected child. But shortly after seeing that, I read a paper that was published of a collection of individuals in Europe, ethicists as well as geneticists, who said, hang on, there's a problem here. Because if you have a lot of money and you want to be sure that you minimize your prospect of having an abnormal child, then why don't you have this? Because you can afford to pay, and there's not really a good argument for it, but I'm going to lean on the medical staff to give me what I want because I'm paying for it. One of the questions that arises, if you're going to eliminate some disease from the community, what happens to those that already are alive and suffering from that disease? Do they become less worthy members of society? And if one can eliminate this, what does it mean to be healthy? Does it mean you have no recessive genes? Probably all of us have a couple of genes with abnormal recessive components that we don't know about. Should we identify those? The company is saying things like, we can halve the risk of having a recessive disease with our test, but they will reduce the risk of having it from 2 in 1,000 to 1 in 1,000. So a rare event, but they're halving the prospect. So there's a difference between absolute risk in numbers and the relative risk of halving. And what do you do with all those embryos that you've found a recessive gene? Do you destroy them? How do you explain a risk of 1 in 1,000 to an average individual in the community particularly if they're buying lottery tickets and they don't seem to understand the probability of success using such numbers. And who's going to make the decisions about whether you should do this or whether you should not, whether this is professionally ethical behavior or should we not? We'll hear a lot more about this because this is the future of commerce in this rapidly moving field, but it raises very interesting and important ethical questions. What is the human race going to look like in the future with or without such interventions? I've jumped around a lot. I hope that's given you some pause for thought, and I hope it's not been too technical, but has got across some of the principles where medical ethics has now a lot to do with sociology, the social determinants of health, equity, fairness, and it's so mixed up with politics. You hear about the postcode lottery of access to medical care. There are ethical elements in there. How does local government function? But I won't stray into any of that, and I'll leave it for your questions if you have it. Thank you very much.
Thanks very much, Ian, for that very thought-provoking presentation. I've got a couple of questions which we've got already. One of them could be the morality of interfering with the reproduction program. What's in the sense, do you think that the embryo has some rights in a way? And if so, when does an embryo have some rights? I.e., because we all know it doesn't sort of, after fertilization, suddenly become a fetus. It's a number of cells, and then it develops. So whereabouts do you think that object, if you like, the cells or something, actually has some kind of status such that it could be thought of as something which needs protecting?
Well, around the world there's an enormous variety of opinions about that. If you happen to be a Roman Catholic, it's the so-called instant of fertilization, which of course is not an instant, maybe takes about 36 hours anyway, but leave that to one side. If you are Greek, the baby, it's only a newborn baby that has the status of a person. But mostly in Europe, one would think that if a baby was viable, that is probably from about 20 weeks, pregnancy being 40 weeks on average. Prior to that, there's a very limited prospect of success. And although one would always treat an embryo or fetus or developing baby with respect, I don't think prior to 20 weeks in the UK, one would consider that to be a person and give it the same status as it would have if it were potentially viable. If you go to Islam, it's probably about 4 months. If you look at the HFEA, Human Fertilization Embryology Authority, they give an embryo particular respect after 14 days. Their rationale being that only at 14 days is the development of a nervous system beginning. In terms of physiology, it's probably about 16 weeks before a fetus can actually sense pain, and there are some experimental data to do that. So I think it depends on how you look at the evidence as to what point in the 40 weeks you actually have a responsive organism. But in the UK, I think most people would say respect from the beginning of conception, but particularly after potential viability at 20 weeks.
Okay, can you see the chat, Ian? If you go to the bottom of your screen, you see the word chat.
Yes,
And if you click on it, you'll come to a question from Bridget and Fred Pink.
I can try to respond to that. Some years ago, it was thought that if there was a complication rate that came at 5%, there was a legal obligation to explain that potential complication. So, and more recently, the lawyers have pushed this down to about 1%. So that if you're going to undertake a particular procedure, you need to talk about the complications that might occur even at 1%. If you're in the States, you would have to produce a list of all possible complications for every procedure. And I have been given 5 pages of potential complications for significant procedures, which of course terrifies the life out of any prospective patient. And the doctor, inappropriately, in my view, feels that he's protected legally. I think that it depends at a personal level. It depends very much on the level of understanding and the nature of the anxiety that an individual has. I think you can talk about the major problems, and if you understand and know the patient reasonably well, then you've got some idea of their anxieties, and indeed you can encourage them to express those anxieties and put the question. But so often the questions are not sought, and it's difficult to know what's actually worrying an individual. I think all surgeons in the question have an obligation to explain potential consequences and complications. And you're quite right. Without that information, you have no autonomy. But one of the problems is I've often spent quite a long time explaining to an individual patient, and then at the end of it, they say, "What would you do?" Or what would you do for your mother? Or what would you do for your daughter? Trying to personalize it and thinking that you would take a different decision. I don't think you would take a decision, because you'd hope to be rational for the family, although perhaps that's more difficult. I think it is important to give options, and sometimes you put numbers on those, and sometimes you can't, because not everyone will respond in the same way to the same set of numbers. I think it depends very much on the circumstances of the individual. And I mean, I always used to say at the end of every consultation, do you have any questions? And that's to my mind, that's so important, because you can't always anticipate all the questions of every individual.
I had another question, Ian, about decision making. Do you think there's any grounds for, in a decision whether a treatment should take place, other than the strictly scientific approach? Do you think there's any decisions which where religious thoughts, that as it's a PCN conference, that's why I come up with that, perhaps trumps the scientific approach?
No, I accept that. Just because I don't think it's what I would do doesn't mean that you shouldn't necessarily do that. And I've been faced with the question of a Jehovah's Witness refusing blood transfusion. And I thought the lady was going to die without her blood transfusion. And this is many, many years ago, and I persuaded her to have her blood transfusion. The consequence was that she was effectively excommunicated by her community. I had not anticipated that. And in retrospect, I wondered whether I had actually made the right decision to try to persuade her. And I've had a similar experience early on in my career, where we were doing exchange transfusions for newborn babies who had rhesus disease, and it can be a lethal condition. And you take out the blood cells which have got antibodies destroying the red cells, and replace them with new red cells without antibodies to save the baby's life. But I've had individuals who refused blood transfusion, knowing the baby would die because they were Jehovah's Witnesses. That's a tough call.
Ian, I've also got a couple of questions from the chat now. One from Rita Baker, which starts off about the question of abortion, and one from Stockport Progressive Christian Network on whether it should have a different point of view because we're progressive.
The question of abortion raises the question of what is a person. If the concept of soul enters the discussion, it raises more questions. When Catholics assert that life starts at conception, that makes the assumption that the body and spirit are formed together. In religions which believe in reincarnation, this becomes a slightly different question. For those who believe that the body is everything and that consciousness is a product of the brain and does not survive beyond the body, then that presumably changes the ethical question again. Do you have any comment to make on that, Ian?
Well, I don't wish to be flippant, but let me tell you a story. Some years ago, I met an American who had been to the Vatican to have discussions in the Curia about early abortion. And they took along a veterinary physiologist who gave the example, what do you do if you have twins? The baby, the embryo is single and it has a soul. Then after up to 8 days, that embryo can split. What happens to the second one? Do you have half a soul each? Do you have one have a soul and the other one doesn't have a soul? Or do you have replication of souls and you have 2 souls? And the Vatican response was, aha, ensoulment obviously occurs at day 8. Which really makes me say that this is an entirely arbitrary decision that fits one's preconceived notions. I think I can't answer that. I think the consciousness is a product of the brain. I agree and doesn't succeed, doesn't survive beyond the body. I'm not sure I can answer that any better.
I can read the next question for you, which is from Stockport Group. Do you think that being a progressive Christian should lead to a different point of view on any of these issues, as opposed to what they describe as a mainstream Christian?
I'm not sure I can answer that at all. What I think is important is that you look at all the evidence. And I can remember before these days of randomized controlled trials were very mainstream, treating an individual on the evidence, and I was very well up on the evidence, and I said, this is the treatment I will give. A month later, they came back and said, could I have some more of that? And I said, no, because there's been a paper published last week, which showed very clearly that it didn't work. So the answer this week is no. And as luck would have it, she came back a month later and I said, there's been another paper published and it says, yes, it is effective. So I'll give it to you this week. So it's ridiculous. And this is where my emphasis on the meta-analysis became very important, that it is possible to summate these and get what you think is the best answer. I mean, I can remember I had a senior lecturer once who put up a slide attributed to me, which said, this is the evidence, and I believe absolutely that this is the approach we should use until tomorrow when the evidence changes. So I can't say any better. I think I'm happy to change my mind, but I would like to see a rational reason for it.
There's a question here from Val Graham, which goes to some of the weighty moral issues. Are you concerned that through genetic testing, the result may be that there may be less people in the world with, for example, Down syndrome or dwarfism. Could this then be perceived that people with these differences are in fact less important or less valuable to humankind?
Yes, absolutely, and I hope that I had pointed that out in one of the slides. I think it's a huge ethical question. I can see that these can be enormously handicapping conditions that one would not wish to have in one's own family. But I think there needs to be support for such individuals as human beings, and they may need special support for long periods of time, and until all individuals with such conditions are eliminated, and that I doubt will ever happen, because not all countries, not all societies are going to be able to afford the technology that will enable you to respond in that way. But of course, that we're not at that stage yet. And I mentioned that the side effects of some of these technologies are by no means understood yet, and I think it's a long, long way to go before we can do that. But it's an outstanding ethical question. Do you devalue the individuals with conditions that you're trying to eliminate?
But surely by saying that, because you talked about just then, you talked about so that, you know, hopefully one day we won't have these conditions. But by saying hopefully one day we won't have those conditions, by default, you're saying that being a dwarf or a person with Down syndrome, they can't live a fulfilling life, or even if they didn't live a fulfilling life, you know, how is being a dwarf or a person with Down syndrome any different to, I don't know, I can't think of another genetic condition that might not be, you know, having the BRCA2, whatever gene is that you're more likely to get ovarian cancer. You still live a fulfilling life, don't you? I feel uncomfortable. I feel very uncomfortable about it, I must admit. I don't doubt, because I have, you know, I work alongside people with disabilities, and I don't doubt that within Down syndrome, for example, it's a huge spectrum, and some are working and others need a lot of care and also have a lot of other physical, you know, heart conditions, etc., etc., etc. But they're no less value. They're no less, as a human being, they can bring joy to their families, and I'm not just talking about genetic things here, but learning disabilities, obviously, whether it be autism, whatever, which I appreciate those things are unlikely. I don't know if there isn't a gene for autism, is there? So you wouldn't be able to wipe out autism by genetic selection. But I just feel really uncomfortable about it, because I just feel that it's, you know, these people they're human beings. They may not be able to speak, but they can show love. They can, and I just worry that just because you're very, very short, or because you can't communicate in normal ways, that the thought that your life would be worth less is just scary. I just feel it's scary.
Well, I understand exactly what you're saying, and I don't have a satisfactory answer except what I've already said. I remember being asked by two couples. I have two examples. I had two deaf individuals who came along asking, could I ensure that they had a deaf child? That was different. I said, no, I couldn't. And if I couldn't technically do it, and if I could, I wouldn't do it, because I've got no consent from the child, and I'm not sure that a child would choose to be deaf if there was an alternative. The extrapolation of what you're saying is that actually we shouldn't do anything to treat anybody, because everybody has a life worth living. I'm not sure I can go along with that. And I think, as I've spent my life in medicine aiming to help people, I would see that I would wish to implement any technology that minimizes societal harm, but the only way I can deal with those that already have those conditions is to provide support, and that means communication and support for them in every way. And they can certainly live fulfilling lives, I agree, but I'm not sure that that would stop me actually trying to prevent that in the first place. That's not a satisfactory. I haven't got a categorical answer, and because I think there are two answers. How do you, they're different questions. How do you stop handicap, and how do you treat handicap? I think they're two entirely different questions.
Well, thank you very much, Ian. I think that's, to say that you've stimulated discussion is probably the understatement of the evening, and I think it's going to carry on for some time in our various groups. And I think as a physicist, I'm more than happy to hear a doctor, a medic and biology coming to the fore, because it seems to me that's what you said. There's an awful lot of ethical questions. But I think I'd like to say, on behalf of everybody, thank you very much for your, I can't really say it was entertaining in a sense, but very useful. It's not quite the right word, is it? Very useful analysis and discussion, which I am convinced many of the PCN groups will, who are here present, will probably take up in the future. And to all the people here, I hope to see you next week when we have Andrew Stern, who's going to look at basically the topic and title, Thinking Science, Thinking Faith, almost from a philosophical point of view. And again, if there's anybody here who's not a member of PCN, my plea is PCN's a pretty good idea. Ian's the kind of person that belongs to PCN. And I hope that you will join all the rest of us. And I hope to see you all next week. And again, thank you very much. Can't really clap, but you've got my thanks there, Ian, for your time and your patience.
Thank you very much. It's been a pleasure. I'm sorry I haven't put much emphasis on faith. I've really stuck to the biology and the evidence. But I think as the evidence changes, I think our attitudes are called into question frequently, and we have many sociological questions to address, really in the guise of health. I think that's for the future. Thank you very much indeed for your attention.
Thank you.